Okay, so what I'm going to do now, and please let me know if there's any issues with which fat quantification in ultrasound. Now, for many, many years, we've been practicing ultrasound, and we've been looking at fat in the liver, and we've been giving a very subjective impression of what's going on. If there's a very echogenic liver, and generally speaking, we compare this with the adjacent kidney and the liver, we call this a fatty liver. And subjectively, we've been saying, yes, it's mild, it's moderate, or it's severe. But what really we need to know is whether that fatty liver is improving. And this subjective impression doesn't give the referring clinician or the patient any idea of how much fat or what the fat content is in the liver, and whether his disease modification practice is actually doing anything useful for the liver. A fatty liver, which is hepatic steatosis, is actually the accumulation of triglycerides within the hepatocytes. And that's a very important bit of information to keep in the back of your mind throughout your careers and whenever you're looking at ultrasound of a fatty liver. There are wide ranges of diseases and conditions that increase your risk for fatty liver. High cholesterol, high triglycerides, obesity, particularly when fat is concentrated around the abdomen, in polycystic syndrome, if you've got sleep apnea, diabetes, hypothyroidism, and hypopituitarism. And it's this metabolic syndrome that is the bugbear of modern living, where you have hypertension, diabetes, fat abdomen, cholesterol. This is the metabolic syndrome. It's almost inevitable when you have a patient who, with all these clinical features, you know you're going to find a fatty liver before you even start doing the ultrasound examination. But why is this finding of a fatty liver important? Non-alcoholic fatty liver disease, NAFLD. This is the accumulation of fat without the presence of alcohol abuse. And it's important because with all the treatments and the management of hepatitis B and C, we're seeing a reduction in the consequences of these viral hepatitis, although we're not seeing a reduction in the alcohol abuse in the liver. But this is also now bringing out the prevalence of the Western style living of a fatty disease. And it's approximately estimated that 20 to 40% of adults in developed countries will develop a fatty liver. And importantly, 1 to 3% of these people will progress on to significant fibrosis. Simple steatosis is not an issue, but it's really difficult to tell the difference between simple steatosis and NASH, which is non-alcoholic steatohepatitis. And this is where necroinflammatory reactions and hepatocellular steatosis occur together. And it's difficult to tease this one out. Simple steatosis, generally a benign clinical cause. NASH, which may be present in up to a third of cases, is progressive and can advance the liver cirrhosis, more importantly, to hepatocellular carcinoma. And NASH is more common in those older people, those with diabetes, and that body fat concentrated in the abdomen. The diagnosis for NASH or a fatty liver is dependent on the evaluation of the biopsy specimen traditionally. And the biopsy specimen gives you the answer of whether it's grade 1, mild, moderate, or severe, and there are a number of entities within that liver biopsy that they look for to classify it. So evaluation remains the gold standard for NAFLD and NASH. But we're not interested in gold standards and invasive techniques. We're interested in ultrasound and non-invasive techniques. But I also draw your attention to this study, which was published in 1995. Now, this is 25 years ago, before the epidemic that we're seeing now of non-alcoholic fatty liver disease. And I just want to take you through briefly what happens here. In this particular study, over a 6-year period, 44% of patients went to NASH, and a high proportion of these progressed to NAFL-related cirrhosis, and a smaller percentage over a number of years developed HCC. With non-alcoholic fatty liver disease, a number over 6 years progressed to fibrosis, and with fibrosis, you again carry the risk of developing cirrhosis and HCC. So fatty liver disease was recognized even 25 years ago to be, in quite a few cases, not as benign as you thought. And because now we're seeing really an epidemic of fatty liver disease, this is going to be the main reason you'll see complications in liver disease in the future. Imaging quantification in fatty livers has changed over the years. Non-invasive imaging methods that are rapidly evolving, not just ultrasound, in looking at these fatty liver issues. We have conventional ultrasonography, which I will talk about in a few minutes. We have CT, we have MRI, elastography of the liver plays a role, not so much in the assessment of the fatty liver, but the associated fibrosis and cirrhosis. But there are, more importantly, quantitative ultrasound techniques that are coming along. You've also got magnetic resonance elastography, and also importantly for the fat quantification, you've got magnetic resonance-based fat quantification techniques. So there's a whole basket of imaging techniques that you can draw on to assess the fatty liver. You don't need to just assess this subjectively on ultrasound. How does CT work? Well, CT has been around for quite some time looking at fatty liver, and it's very easy to pick out that low attenuation fatty liver. Using unenhanced CT, the normal attenuation value of the liver parenchyma is 50-60 5 Hounsfield units, and it's typically the spleen is higher. But steatosis manifests itself as a low attenuation. You can evaluate a fatty liver by the absolute attenuation value, the attenuation value differences between the liver and the spleen, or the ratio of the liver to spleen attenuation values. But it has limited diagnostic performance for quantitative assessment of mild steatosis. It's better at detecting moderate to advanced steatosis. MRI, well, MRI is now regarded as the definitive imaging tool to qualitatively and quantitatively evaluate hepatic steatosis, and it's this protein density fat fraction, the PDFF, that is most important. And it's the ratio of the density of mobile proteins from triglycerides and the total density of proteins from mobile triglycerides and water. So it's expressed as an absolute percentage from 0 to 100%. And importantly, with this technique, you can do in a single breath hold, short breath hold, and it takes less than 25 seconds to perform. So it's a simple tool, but you've got to have that expensive MRI examination available to you. Ultrasound has some semi-quantitative techniques in which to quantify fat. As opposed to MRI, ultrasound is so inexpensive, it's non-invasive, and you'll never find a patient refusing to climb onto your ultrasound couch. You may find many patients refusing to go into the MRI machine. However, ultrasound has this advantage of operator dependence, and important. It's difficult to interpret in the very patients you want to assess for fatty liver, those with bad body habitus, and this contributes into variability and just reduces the sensitivity and accuracy of it. And on the basic ultrasound in hepatic steatosis, you're qualitatively or subjectively looking at your liver kidney contrast changes, vessel blurring, posterior beam attenuation, areas of focal fatty sparing, and whether or not you got that good gallbladder and diaphragm visualization. So presence of steatosis is inferred, too bright, or if the structures are blurry or poorly visualized. And you can grade it on this, and this grading is a very subjective grading, as you would imagine, absent to mild to moderate to severe. And in the severe cases, you've got marked increase of liver echogenicity with poor or no visualization of the portal vein down the posterior part of the right liver. And I think we all practice this by assigning a score to what we think that liver steatosis is and pass this on to the referring clinician. Now, you can imagine if someone's trying to reduce the fat in the liver, this sort of score is not helpful to tell you whether or not you're being successful. Recently, in 2019, in abdominal radiology, we had a paper from a group of experts where they shared a number of patients' ultrasounds between them and were asked to look for various markers of steatosis. And in fact, the areas which gave you the best interpretation of whether there or not there was a fatty liver was large hepatic vein blurring, liver to kidney contrast, but more importantly, just the overall impression of the readers. These had the higher agreement. And these are the sort of images you're looking at for very severe blurring of the image. So yes, you've got some parameters, but in expert hands, these are useful. You want to have something that's easily reproducible between different observers. So the limitations of conventional ultrasound for non-alcoholic fatty liver disease evaluation is it's subjective. The value of ultrasound to evaluate it is very difficult because you can't often differentiate mildly fatty livers from normal livers. And so and also it decreases with body mass index. So very people you want to actually give a good quantitative assessment of the steatosis. And you cannot tell the difference between a fatty liver, steatohepatitis, or stage fibrosis in any way. There is another aspect to this, is the hepatorenal steatosis index, and this is where you're comparing the liver and the kidney, and you're making a measurement of this. And the first paper, or one of the early papers in this, of Marshall's group, looked using a Hitachi EUB 8500 system and looked at a histogram analysis of the echogenicity. And they had a cutoff of 1.34, gave a 92% sensitivity and 85% specificity for identifying steatosis of greater than 5% in patients. A second group later on looked at the DICOM images and directly from PACS and used the markup region of interest as a tool. So these were cumbersome measurements, but it showed that you could do it to give you some form of hepatorenal index to give you an idea of the degree of stenosis. This more recent paper in 2014 looked specifically using, and they were using an Axon-Antares system, and again they were using quantification on their DICOM images and computer-based algorithms, and they had cutoff points for steatosis of 1.28 for 5%, 1.75 for 25%, and 2.1 greater than 50%. And if you look at these box and whisper charts, you'll see there is quite a lot of overlap between these two groups, but it can clearly show you and quantify the difference between a normal liver and a severely fatty liver. So there are tools out there which are semi-objective in a way. And they suggested that this could be a very useful tool for the assessment of steatosis. Recently, Samsung have produced a system with software called EZHRI, which automatically measures the brightness of the liver parenchyma, the brightness of the kidneys, and it does this by using extracting the region of interest and using deep learning and artificial intelligence to select out the of the kidney. So you're actually measuring the cortex to the hepatic echogenicity, and it gives you a chart of what that HRI or the ratio is. And it automatically places these chart areas for you, but it doesn't always get it right. Here it's not identified the liver edge because this patient has got a blurred edge and there's a lot of fat tissue in between. And of course, you can't use this if the patient's kidney is also bright if you've got chronic renal impairment, and here the ratio is 0.32, as opposed to this where it's 3 times more reflective. But I show you this picture in a child because this is where these sort of measurements and usefulness is for assessing the hepatic fatty change, is because in children there's increasing incidence of fatty change, and it seems that they have advanced fibrosis at diagnosis much sooner, and it seems to be that the fatty liver may be more severe in children. So we got to really keep an eye on children with and this is very easy to button, and the second button will allow you to optimize where you put the regions of interest. So adding it into your ultrasound examination is a simple technique, and other machines are developing a similar sort of thing. But there are other techniques that you may use. You may want to use different signal changes that the fatty liver produces. We've looked at echogenicity, but also remember that there is attenuation of the sound beam, and there is also backscatter. And you can make use of both these parameters to actually give you a quantification of the degree of attenuation and backscatter in the liver. That produces a quantification for the amount of fat contained in the liver. If we look at backscatter coefficient, which is something that's been around for quite some time, this quantifies the scattered signal distribution based on backscattered signals. Scattering produces speckle in the ultrasound images, and the speckle pattern based on gives you an intensity of the scattering. And then you can model this on a Rayleigh coefficient to tell you whether or not and how much scatter there is. So in this particular example, the probability of a normal healthy liver with your scatter index less than 100, and here you've got a severe fatty liver if your scatter index is greater than 100. I have to emphasize this is very much a research tool at the moment, and we have no basis to base this on any clinical studies at the moment. However, this has been around for quite some time. This is a paper from 2004 by Diana Ghiattini's team in Israel, where they actually looked at fatty liver biopsy and texture and attenuation and backscatter. More recently, Lin et al. Published in Clinical Gastroenterology Hepatology in 2015 compared the backscatter with PDF sensitivity and specificity using this technique. So early days, but it's coming through that you may use this to quantify the amount of fat in your liver. And this is just an example of a patient where in a normal liver, the TSI, the index is 65. As you're getting a little bit fatty, this is a promising technique, simple to use, and we may see this in clinical practice soon. The other way you can look at that is to look at tissue attenuation, quantitatively measuring the attenuation of signals received from the liver, as there's a gradual loss as you go through the liver through absorption, reflection, and refraction, and all of this changes with the amount of fat you have in the liver. But importantly, this attenuation is frequency dependent. So there's more attenuation with higher frequency, and this is important, as I'll show you in a study later on, as we go further through this, that how this is as well. Just have different attenuation coefficients, but we'll the liver, and that shows us what the attenuation coefficient should be like normally. This has been around for a little cap that's attached to the and FibroScan is a tool that's mainly used by hepatologists to quantify fibrosis, but this is controlled attenuation parameter and it's expressed in decibels per meter. And this has been worked out in a number of studies now, and you can measure the cutoff for S1, S0, S1, S2 as mild, significant, severe steatosis, and there are numbers that come out to give you this cutoff. There are some using attenuation of the FibroScan when you're assessing fatty liver because it's easy to perform, immediate results, inexpensive compared to other imaging modalities. It's all controlled and is operator dependent. It's reproducible. It's less influenced by a sampling error compared with liver biopsy because it explores a liver volume of 100 times larger than a biopsy. Targets specifically the liver, guided by your baseline measurements for the VCTE, and is evaluated along with the shear wave measurements, which correlate with fibrosis. So you have a tool that gives you how much fat there is in the fibrosis is there, and it's thought that the fibrosis does not affect your measurement of the fat. But there are disadvantages. There's a measurement failure in 7.7% of patients, harder to do in female gender, And yet again, it's harder to measure in the very patients, the high BMI and metabolic syndrome, that you want this measurement. Quality criteria are not defined. You use IQR in the shear wave measurements. It performs less well than ultrasound, and it performs less well when there isn't advanced liver fibrosis or chronic viral hepatitis. Optimal cutoffs may vary by 10 decibels. The concordance may be as high as 20 decibels. There's again overlap of grades and cutoffs between studies, but I emphasize that this is a preliminary result and there's some time to go yet before we actually establish this sort of technique in clinical practice in a robust manner. And when you use this, and this is again from the Samsung machine, you're looking at attenuation, you've got to place it in the right area. You've got to exclude major veins, at least 3 centimeters from the liver capsule. Patients got to hold their breaths, and you've got to in machine measurement value that tells you whether or not it's accurate. And this 0.9, that is an accurate measurement. But if it drops, the R2 drops below 0.6, is displayed in red on this particular machine, you haven't got an accurate measurement. And remember, don't put it over the veins. And this is where you'll get issues with accuracy of measurement. I'm just going to write the last few minutes, just bringing to your attention some studies that are using now this novel ultrasound-based technique of using attenuation values with an ultrasound machine and using it against gold standards. So this particular study from a group in Pavia in Italy, led by Giovanna Frioli, looked at comparing comparing as gold standard the protein density fat fraction measurements. So it wasn't against biopsy, it wasn't against the absolute. So what they found in this study was that when you add the fat attenuation to the ultrasound machine and used also the FibroScan cap, there was, but you can see again there remains some overlap in the different areas, different levels of fat change. So it's as good as cap in it produces that same. And they could measure cutoffs. Now, the ATI with the ultrasound machines measures it slightly different. So the ATI measurement is 0.72 decibels per centimeter per megahertz. So this means immediately your measurements are not transferable between the two machines. And they had cutoff points that were quite clearly defined. So the study actually showed that this technique well with the PDFF, but the correlation was significantly higher than that of CAP. So it was better than CAP in comparison to a gold standard. And this translational impact was that once you've employed it on an ultrasound system, you get everything there. You get the morphological evaluation of the liver, assessment of the biochemical properties, you get the elastography. So it's developing time and you're improving your steatosis measurement. But I did mention earlier that it depends on frequency of the transducer you're using. And this is the same group where they were comparing 2 different probes, which they called the ATI penetration and the ATI general. Penetration was at 3 megahertz, ATI general at 4 megahertz, and they compared it to CAP. And the difference in the measurement values between those 2 probes. So you've got to now be sure that you use the same probe at the same frequency if you're following up these patients. And just looking at that ROC curve, it shows you that the ATI and the ATI pen, which is the ultrasound-based attenuation values, outperforms CAP, which is the FibroScan technique, in lower areas of steatosis. But they all more or less come together when you've got severe steatosis. Very simple to use, and this is now embedded in the Samsung. We use all 3 systems on the machine to look at TAI, TSI, and the HRI. And again, very simple and straightforward to use. A single button gives you, introduces you to either one of those two areas. You can press another button, it gives you the TAI, another button, TSI. Important thing is it's simple and easy to use and quick. It doesn't delay measurements within the clinic. And also then you get a display, as all the different manufacturers will do for you. You get a display and a report which you can present to the clinician. And more importantly, you've got a set of figures on which to base improvement or deterioration in the patient's fatty liver. So just to conclude, accurate estimation of fat in the liver is important in diagnostic workup for patients with non-alcoholic fatty liver disease, because this is now going to be the major cause of liver disease in the future, and you need to quantify it. Ultrasound B-mode imaging, which is widely used for screening of liver disease, allows subjective estimation of fatty liver infiltration in the liver, but it has low performance for the detection of mild steatosis. And so semi-quantitative scores have been developed, but more important, quantitative scores are becoming available. It's still early days and they do it in different manners, and we don't have any long-term prospective studies evaluating these, nor have we decided what the goal can be for which to compare these studies. Thank you very much.